Good evening, all the aspirants present here. Today topic is domain renal, and the speaker that we have here today is Dr. Nikhilesh Jain, who is a director and operational head depth of critical care services care at CHL Hospital Indore. All the students are requested to hereby drop the question in the chat box. During the Q&A session, we'll be answering those. And please, everyone is requested to mute their mics. Thank you. Sir, please start your session.
Today we'll be doing, certain questions on renal domain. And these questions would later on be, they are more case-based. And once we are done with them, then there would be a brief discussion somewhere later on in the debriefing part. So this is the first case, you've got a 34-year-old male who presents to the emergency department with severe muscle pain, dark colored urine, and generalized weakness for the past 24 hours. Now, he reports completing an intense CrossFit workout 2 days ago, which included multiple sets of weighted squats and deadlifts. He denies any prior history of similar symptoms. So, some more details that may be given to you would be when it comes to vital signs, BP is 125 by 80 mm of mercury, heart rate of 98 beats per minute, temperature of 37.3 degrees centigrade, and respiratory rate of 16 beats per minute. On general examination, he's alert and oriented. He appears uncomfortable due to muscle pain. From a musculoskeletal point of view, you have got a bilateral thigh and calf tenderness with mild swelling. Neurologically, there are no focal deficits. Your DTRs or the deep tendon reflexes are normal. Elevated serum myoglobin levels and serum creatinine levels are noted, with a low urine output probably going towards the range of an oliguric range. So I guess most of you would have got the diagnosis by now, right? And can you just put in the chat box, what do you think this is? In the chat box, I don't want to open everybody's mics. This is correct. Pawan has given the answer, and this is what I think most of you should have been able to get it. This is indeed rhabdomyolysis. And when we look at the questions that can come out of this, the first question would always be, what is the diagnosis? Then second one would be listing of the electrolyte abnormalities which are commonly seen. This could be all your hyperphosphatemias, potassium, calcium, uric acid, these disorders, which are commonly noted in rhabdomyolysis. Then what would be the diagnostic test? That would come next. Whether you would attach credence to clinical symptoms alone, whether you would attach credence to myoglobin levels alone, whether you would attach credence to proper history, whether there is a diagnostic algorithm to that all would be covered in that. Of course, the next thing would be what would be the role of urinary alkalinization in that. Can anybody say anything in this? These are fairly standard questions. You can again put it in the chat box. So what is the diagnosis is done and finished. Then you have to list what are the electrolyte abnormalities which are commonly seen in rhabdomyolysis. Now, let me tell you, this can happen in different stages as well, in terms of what stage of rhabdomyolysis you are seeing. So that needs to be remembered and sorted out. And of course, the diagnostic test, as I told you. And what would be your differential with that? So that is how you would like to differentiate it with hemoglobinuria. You would like to differentiate it with maybe anything else. So what would be, but the most prominent thing that I would like you to differentiate it with would be either RBCs in urine, that is hematuria, or hemoglobin urine, right? Then comes a question on role of urinary alkalinization. Is there a role or is there no role? Or maybe a limited role in certain settings, right? So this would be again taken up during the debriefing part. And what are drug-induced causes for the same? This would be a list wherein you would be actually doing certain drugs that would be causing rhabdomyolysis. Can anybody put some of them in the list? Okay, that is one. What else? Statins are one of the commonest drugs that are being prescribed nowadays. Anything else? Antipsychotics. What next? Okay, so I've already got some of them in the list. And as it goes on, uh, again, this would be discussed in detail during the debriefing session. Then you need to list the complications of the above. Now, what are the complications? Sometimes people can get confused, but complications meaning what all can it give rise to? It can give rise to DIC. It can give rise to multiple other organ dysfunctions because of metabolic acidosis. So all those things need to be mentioned in that order, right? I'll go on to the second case vignette now. So this is case 2, 72-year-old male, history of hypertension, type 2 diabetes mellitus, chronic kidney disease. You've got a CKD stage 3. And this male presents to the emergency department, ER, with chest pain radiating to his left eye. It was found that this guy has coronary artery disease and they performed an urgent coronary angiography with contrast on him. His past medical history included hypertension, type 2 diabetes with an HbA1c of 7.8, CKD stage 3 with a baseline creatinine of 1.6 milligram per deciliter. And the medications that he was on included metformin, lisinopril, aspirin, and atorvastatin. He did not have any allergies. And in terms of recent procedures, he had undergone a contrast-enhanced CT angiography 2 weeks ago. So some more details about the same. Vital signs included BP of 138 by 84 mm of mercury, heart rate of 76 beats per minute, respiratory rate of 18, temperature of 36.9 degrees centigrade. General examination, no distress, alert and oriented. Cardiovascular, no murmurs, no signs of heart failure. From a renal point of view, there was no costovertebral angle tenderness. There was a mild bilateral lower extremity edema. 48 hours after the coronary angiography, the patient reports decreased urine output and generalized. Now, the baseline creatinine, which earlier was 1.6 milligram per deciliter, goes up to 2.3 milligrams per deciliter, which is a 48-hour increase of 0.7 milligram per deciliter. BUN, that is the blood urea nitrogen, was 38 milligram per deciliter, which was elevated. The patient develops mild hyperkalemia, urine allergy, and on urine routine examination, this patient has muddy brown casts with no protein. Can I have the diagnosis again in the chat box? What do you think is happening here? This is simple. Can you give me the answer in the chat box? Yeah, this is fine. This is fine. So somebody has mentioned it. This is basically contrast-associated kidney injury. It is no longer rhabdomyolysis with hyperkalemia, Pika. And Sanjay has told correctly, it is contrast-induced nephropathy or maybe a contrast-associated kidney injury. And so what is the diagnosis? Yes. Now, can you establish a causality for the same and what are the risk factors? So we need to mention what are the risk factors which will predispose an individual to developing a contrast-induced nephropathy. And whether is there in current era and current literature, is there a direct causality that can be established in terms of worsening of kidney function happening directly and purely because of the contrast-associated injury? That is one. Then you need to enumerate whether there are any risk prediction models. There is one actually, and you need to mention it. What are the certain variables that may be included? Now, when it comes to prevention, of contrast-induced nephropathy. Of course, everybody knows about hydration, and of course, everybody knows that N-acetylcysteine may not work that well, but certain specifics of the same, um, a little bit about vitamin C, a little bit about bicarbonate, all these things should be something that you should be able to mention. Then any correlation with contrast agents, you need to tell everybody whether what type of contrast agents are more likely to cause it, and how do the isoosmolar or normosmolar isoosmolar contrast agents fare in giving rise to a acute kidney injury. So again, this would be discussed a little bit in more detail about during the debriefing part. This is the third case. So now you've got a 28-year-old woman. This is gravida 2 para 1. She presents to the emergency department 1 week postpartum with complaints of severe headache, confusion, bruising, and dark colored urine with history of normal vaginal delivery at 39 weeks without complications. Vital signs include BP of 148 by 92 mm of mercury, heart rate of 110 beats per minute, temperature of 37.2 degrees centigrade, and a respiratory rate of 18 per minute. On general examination, this lady is pale, mildly jaundiced, alert but confused. Neurologically, she is disoriented to time and place with no focal deficits. On skin, she has multiple petechiae as well as ecchymosis on upper limbs. Abdomen is soft, non-tender, uterus is well involuted. Some more details. Platelet count. She's got severe thrombocytopenia, 18,000 per microliter, with a hemoglobin of 8.2 grams per deciliter, and schistocytes are seen on blood smear. LDH values are elevated in the form of 950 units per liter, and haptoglobin is undetectable. Creatinine levels are 2.1 milligram per deciliter, signifying acute kidney injury. Indirect bilirubin levels are elevated. Then you've got coagulation studies in the form of PT, APTT, along with fibrinogen D-dimer. All of them are normal. And you've got an ADAM-TS13 activity, which is less than 10%. So again, in the chat box, can you tell me the diagnosis? This should again be simple enough. I've given a big clue with ADAM-TS activity there. No, not HUS. Yes. So Pawan corrected himself. Salah has now everybody is giving TTP. So now everybody has sorted it out. It is TTP, right? So the type of questions that may be asked to you, again, this is a point in time wherein acute kidney injury happens because of TTP. So the type of questions that may be asked to you will be one, of course, which you got it, what is the diagnosis? Second one, what would be the confirmatory test? So you need to be very well aware about any algorithms, equations, and lab abnormalities that may be, you may be encountering in that. You need to also know in the second set part of the answer, that is the last section of the answer, when I talk about differentials, probably you need to know other causes of myelopathic hemolytic anemia as well. Then is there any algorithm to validate the diagnosis? Yes, there is an algorithm. You need to go through it and probably a little bit about, you should be knowing the scoring points and a little bit about what are the variables in. How to treat the same, everybody can jump on Plex, but there are certain drugs that are used. You should be also aware about them and you should be able to mention them. So again, details in the briefing session. Now, case 4. You've got a 54-year-old male with a recently diagnosed acute myeloid leukemia, presents to the emergency department with complaints of nausea, vomiting, muscle cramps, and decreased urine output 2 days after starting induction chemotherapy with cytarabine and daunorubicin. When we look at the past medical history, this patient had hypertension and hyperlipidemia. Medications wise, this patient was on amlodipine and atorvastatin. Recent symptoms included fatigue, weakness, nausea, as well as dark colored urine. Now, when we talk in terms of vitals included BP of 130 by 85 mm of mercury, heart rate of 102 beats per minute, temperature of 37.1 degrees centigrade, respiratory rate of 18 per minute. The patient appears mildly fatigued and might be dehydrated with oliguria and muscle weakness with cramps, right? So there's some more details. ECG is suggestive of findings of peak T waves and a widened QRS. I can leak that a little bit, maybe, hyperkalemia setting in. Creatinine, 2.4 milligram per deciliter, more in favor of acute kidney injury, and BUN, or a blood urea nitrogen level of 34 milligram per deciliter. So again, what do you think is the diagnosis? Ah, this time no mistakes. Priyanka, Salah, both have got it. Vijay has also got it. Okay. So what are the things that you would need to know in this? First, of course, what is the diagnosis? Second one, what are the electrolyte abnormalities which are commonly described with the above? All of them you should be able to tell. Thirdly, of course, how do you treat this patient? Just a little bit about hydration, just a little bit about correction, and what all you need to give. Is there a specific drug also that comes into this? So some specific drugs that may be required. Then how do you grade the tumor lysis syndrome? There is some sort of scores and algorithms which you should know. And again, what are the indications of renal replacement therapy in a patient of TLS or a tumor lysis syndrome? And if you are doing renal replacement therapy, some amount of knowledge on what type of modality is the one that you would prefer for these particular patients, right? So next, this will be the last case. Then after that, we'll be doing just pictorials. So here, what we have, you have a 32-year-old male farmer. This man is brought to the emergency department 4 hours after ingesting poison in an apparent suicide attempt. Now, he complains of burning mouth pain, nausea, vomiting, along with difficulty in breathing. His family reports finding an empty pesticide bottle near him. Now, his vital signs include a blood pressure of 110 by 70, his tachycardic, heart rate of 115 beats per minute, respiratory rate of 24 per minute, temperature of 37.2 degrees centigrade, and SpO2 of 91% on room air, obviously low. General examination wise, he's conscious but distressed, shows moderate dehydration. Oropharyngally, he's showing certain oral ulcers and mucosal burns. He's got mild tachypnea and bilateral crackles on RS examination. From a cardiovascular point of view, there's tachycardia but no murmurs. From GI point of view, there's mild epigastric tenderness with no cardiac. We'll go into some more details. We did an arterial blood gas on him, which showed a metabolic acidosis with a pH of 7.28, PaO2 of 78 mm mercury, and PaCO2 of 32 mm mercury. Obviously, going towards hypoxia, obvious metabolic acidosis. Renal function suggestive of acute kidney injury in the form of elevated creatinine to the value of 2.3 milligram per deciliter and BUN of 38 milligrams per deciliter. Liver enzymes are mildly elevated. Electrolytes wise, he's got a mild hypokalemia. Chest X-ray suggestive of diffuse bilateral infiltrates, which is early lung injury. So questions is, okay, I should have again. So in the chat box, what do you think this is? Correct, Vijay. That is correct. So this is indeed paraquat poisoning. And when it comes to paraquat poisoning, there may be certain questions that may be framed out of it. So what is the diagnosis? We've done that. How do I confirm the same? You need to tell what is the specific test that can be used, what type of assays or what type of measurements can be done. So all these things need to be measured. Vijay, we'll need to do more, not dithionite alone, but anyway. So, okay, then how do you treat the same? That also needs to be specified. What is the timeline under which definitive therapy has to follow? Then what is the correlation with serum creatinine levels? There's a marker called a cystatin C. So we should know a little bit about cystatin C whenever we are going to discuss the paraquat poisoning. And of course, there are certain name-based predictive nomograms when it comes to paraquat poisoning. We should be able to define the same and we should be able to tell this, right? So next would be, what is this? Indications for use. You would have all seen this actually, but what we need to know is, of course, what is the type of uh, device that is being shown here, or what is the type of an attachment that is being shown here, and where exactly does its application lie when it comes to practices in patients of acute kidney injury. Or for that matter, okay, I'm giving in a clue. Uh, correct. Priyanka has got it correct. So we need to give a clue in terms of where all we can use this. In that sense, you will be also required to know the indications of hemoperfusion, or what are the type of poisons that can be removed by hemoperfusion. And this thing is basically a charcoal cartridge, right? So the name tells you, what is this, but where is it useful? We need to define its exact place in the management of AKI patients. We need to know how best we can use, it's a marker, and how best we can use a marker. And where are the situations wherein it would have a prognostic impact, or maybe a progression related impact, about how you can track the acute kidney injury, about how much time it's taking, and whether it's getting better or whether it's getting worse, right? Then this is another question. So what do you think this is, and what is the application? So this is also another thing. This is an index actually. So where do you use this index would be something that you would be required to know in terms of diagnosis of acute kidney injury. Somebody wrong. Correct. Priyanka is on fire. Line says she's answered all the three answers last one. Okay, fine. So you will need to know certain specifics of this, and we will discuss that in the debriefing session. Okay. So this is basically a CT scan image. Are you all able to see it clearly? Can I have a show of hands? Are you all able to see it clearly? I need to have a vocal cue on that, whether you are able to see it clearly or not. Okay. Okay. So all of you have got the answers, but how do you treat it for a diabetic patient is something that will form the second part of the answer. That is something we will need to discuss, right? And this is the last one, actually. Yes, this is the last one. Uh, what do you see in this image? And again, how do you treat this, right? This is also again a very classical CT image, something that you can see very clearly. No answers this time? You should be. It looks simple enough. No, not at all, Sana. Not at all. Anyway, no problems. We'll discuss the rest of it during the debriefing part. Are there any specific questions related to these things, or any doubts regarding the case vignettes that were asked for? We would be doing a debriefing session, and in that, all the answers would be hopefully done. Priyanka, I'll tell you, I'll tell you during the debriefing session. So that's not a problem at all. Don't worry. We'll discuss that particular thing, right? I would close the meeting for now, and I would close the meeting for now. There would be a debriefing session for this, and once we've done the debriefing, then you would be able to see these answers in much bigger detail, right? So that's it. I'll give you some food for thought. Go ahead, finish off these questions, and then we can plan accordingly. Thank you so much.